So please be conscious about, you should have a thing popped up on your screen right now saying that it's being recorded, as I did. And so just be aware of protected health information that you choose to share, because this will be recorded, so it's a choice on your part. I'll go over in a second more about the how we're going to gather comments, but we're going to be using the chat and what we call the speaker's queue. There's a link on the screen also right now for those of you who are online, to get the slides. And if you're listening by phone, as always, press 6 to unmute and then 6 to mute again once you're done. And if there's background noise, we will go through the mechanism of the webinar here through Zoom and see where the source is, and we'll mute certain phones or certain computers where there's background noise getting in the way of the meeting. You can also raise your hand in the webinar by either clicking on the reactions link at the bottom of your screen, or by pressing 9 on your phone if you're on phone. 9 to raise your hand, then *9 again to lower it. And you can click a button to receive closed captions or see closed caption for this. And we have a link there to the webpage for the meeting information. If you want to do that or save it for later, save it to your bookmarks. Next slide, please. Slide number 2. We're there, thank you. So we want a chance to hear from everyone who wants to speak. And the best way that we can do that we've figured out in the meetings that are of this size is to use the chat and to use the raised hands in the webinar. Everything will be posted to the Case Management Redesign webpage for review. You can go there to review it, go there to find updates. I will make every effort to get to all comments, requests to make comments, but we may run out of time at certain points in the meeting and we'll need to move forward. We do then always have the chat for you to type in a comment, and so that will be captured. We are also going to be placing an attendance form link, it's a Google form, I believe, in the chat. So please fill it out so we know you're here and you're attending. We will have time at certain points, designated points in the presentation. You'll see a big slide that says questions and then a question mark. Those are the times when we will be gathering comments and responding to comments as best we can verbally or in writing that come from the chat. So you can type a comment or question in the chat. We will also take comments from the speaker's queue. The way that we'll handle that, to get into the queue, you can type your name. So it would be, in my case, John for the Q. You can use the letter Q as a short acronym for that. Or you can raise your hand in the webinar, again, the reactions button on the bottom. Or I will also, for those who want to choose to give their comments verbally over their computer audio or by their phone, I will ask for those names only, and then I will come back and take your comment in order, and I will alternate between the chat, I believe, as best I can, and the speaker's queue. So when I ask you for your name, unmute your phone, *6, or your computer audio, give me your name, and then mute again when you're done with that, and I will come back to you. Okay, thank you very much. I'll turn it back over to the rest of the team. Next slide, please.
Great. Thank you, John. I appreciate that. And I appreciate all of you joining us this morning. So with us today is Colin Laughlin, our Office of Community Living Deputy Director. He will be doing some introductory slides and talking about the history and background and how we got to where we are today. And then if we go to the next slide, the agenda for this morning, after Colin goes through the background and the redesign direction, I will then talk about the Case Management Agency defined service areas and how we arrived at the new service areas. We'll talk about member portability and grievances, processes, community center board, designation, We'll have an update on organized healthcare delivery system and the Human Rights Committee. And then we'll round out the meeting with quality case management, training, and rates, and then discuss what all of this really means for members receiving services and have space for questions and comments. And so we try about every 6 months to do a really broad stakeholder engagement and provide updates on the work that's been happening, around all of the case management redesign activities. So with that, Colin, I will turn it over to you.
Great, thank you, Amanda. Good morning, everyone. As Amanda was saying earlier, it certainly feels like winter is here, a little colder than I recall, but here we are. I hope everyone had a great Thanksgiving and really appreciate you joining us today. Like Amanda said, my goal really is to give people a sort of overall background of how we got here, where we're going, what is changing, what is not changing, but also lay some groundwork in terms of what are home and community-based services, how they operate here in Colorado. So I have a couple slides here that I'll go through, and then Amanda will cover one slide, and then we'll have an opportunity for questions sort of on this background set. So with that, if we could go to the next slide, please. So pretty basic slide here, but we wanted to make sure that we set the level here for everyone to really understand what we're talking about. So what are home and community-based services, or HCBS waivers? Really, what they are alternatives to institutional care. And what this means in particular is that in the United States, states can develop these services as alternatives to institutional care, like nursing facilities, like hospitals, like intermediate care facilities, and receive federal matching dollars. This allows people to receive those community services in their home or a resident of their choosing, instead of those institutional settings. That was, the majority of people would receive services, say, back in the 50s and 60s, even through the early part of the 70s, really seeing that change in the 80s and through the 90s. And what this really does is two things. One, it allows people to choose how they receive services, where they receive services, in what manner, who's providing the service in many cases, and it really improves quality of life. There's thousands of studies out there about how this improves quality of life and allows for lifelong community engagement. It also has the benefit of typically being less expensive than those institutional placements. And so with these waivers, what we're able to do, and the reason that we call them waivers, is that we can add additional flexibilities that allow us to waive some normal requirements of base state plan Medicaid. So we're able to target specific criterias or waive income or eligibility. So for example, we can target the brain injury population and provide those services. And it allows for that both geographical area to be targeted, but a diagnosis or injury, oftentimes where you live, and really ensures that we're trying to build those community-based services to meet the need of that specific set of individuals, broadly speaking. And it allows people the greatest amount of choice in how they receive services, where they receive services, and what fashion they receive services. It really empowers people to be in charge of their own health. So what are the waivers in Colorado? We can go to the next slide. Colorado has currently 10 home and community-based service waivers. We used to actually have 12, which led the nation in waivers. We've since combined some of our waivers and put some additional benefits under other authorities. And so now we have 10. Those, as you can see, have broken to the adult waivers, and then the children's waivers, where we have 4, and the adult waivers, where we have 6. These waivers are often split into sort of 2 distinct populations or overall populations, where we have the intellectual and developmental disability waivers with the DD waiver there, and the supported living services waiver, the developmental disabilities DD waiver, and the supported living services waiver, and then the children's extensive supports waiver. The non-IDD waivers, brain injury, community mental health supports waiver, complementary and integrative health waiver, formerly known as the spinal cord injury waiver, and then the elderly, blind, and disabled waiver. On the children's side, we have the Children's Home and Community-Based Service Waiver, or CHCBS, the Children's Habilitation Residential Program Waiver, or CHIRP, as it's often referred to, and the Children with Life-Limiting Illness Waiver. Again, in Colorado, we do have those 10 waivers. That is quite a few to administer. With CMS, that's a lot of back and forth administratively. And so one of the things that we continually look at is how to create efficiencies in our system. And there's certainly conversations about how we continue to do that. So how does this impact case management? How does this system look when it comes to how people oversee that care and oversee how people are accessing those services? If we could go to the next slide, please. So we do have differences in terms of how people receive those case management services depending on the waiver. Colorado, with those 10 waivers, has 3 different types of case management agencies that focus on those different waivers and different populations. So single entry points serve the non-IDD waivers through the BI to the EBD waiver, as you can see there. Community center boards serve the CES, CHIRP, and DD waivers, as well as SLS. And then private case management agencies serve the CHCBS waiver. So as you can see, that's quite a bit of difference, but depending on what the baseline waiver is, and really can create confusion, especially as we see people with different disability types or different diagnoses be eligible for multiple waivers. The system can be confusing. So in order to bring about the change, what kind of got us to this point? We can go to the next slide. So first and foremost, in 2014, there was an executive order and a set of recommendations that were put out by the Community Living Advisory Group, which was a governor and a legislative branch appointed group of individuals that got together to really talk about the direction of Colorado's community living plan, how we can really ensure that the department and its partners, its other agencies that we work with, we're focusing on community integration and community placement. And what this really found in that first piece was we needed to redesign case management to better support members, ensure that we have quality case management services in their homes and communities where they could go to just one place and make sure that that complexity that you saw on the last slide, breakout by waiver, was tamped down. Additionally, sort of at the same time, we also had the federal government enacted a rule that many people just refer to as the final rule or final settings rule that brought about sweeping changes that required states ensure community-based settings were truly integrated into the community, but relevant to this piece, also got conflict out of case management. It required that case management agencies could not provide services to the same person they were responsible for case management. So with that, we undertook conflict-free case management efforts. And really what that has done over the years with stakeholder input has brought us on this path. So really it was several efforts overall with the department, its stakeholder partners, its executive branch partners, people in the legislature, really focusing in on how we can innovate this system. So we embarked on that journey to both create a new assessment that better supported individuals in the person-centered support plan process, really put the individual at the center of all that planning, and made sure that as we redesigned the system, we weren't losing things that made Colorado really a leader in HCBS nationally. So what is the direction that we have taken thus far? We can go to the next slide. So how did we come to this structure? What have we considered otherwise? Have we looked at other ways of doing this? What have other states done? How did we come to this particular moment in case management redesign? These are all great questions. As you can imagine, we get them frequently and we're always happy to answer them. I think first and foremost, I think we had someone pop on. If you could just hold on a couple slides, we'll have questions here momentarily. If you could all make sure you're muted, that would be fantastic. First, we are uniquely Colorado. Colorado is already unique in our structure. We have more waivers than most states at this point. We have a unique system of dissemination of services and support. We are already different than apart from other states. So it really doesn't make sense for us to take a template for another state. that may have managed care, which we do not have in Colorado, that may have different regional operating entities that we do not have here in Colorado under our home and community-based system, and sort of figured out how we can do this on our own. So what we did in order to come into compliance with conflict-free case management was really flip that question around a bit. Knowing that we had to do that, we had to come into compliance there. How could we make sure that we were also having these stakeholder conversations? How could we make sure that we were incorporating all of the changes and innovations that we wanted to see system-wide, and take this opportunity to really change the landscape of case management in Colorado? So to that end, first and foremost, we did a lot of stakeholder engagement. I recognized quite a few names when I was looking at who is participating. Many of you have been here since the beginning, and we thank you for that. But what we heard throughout the entire kind of arc of this conversation is that the siloed system of having different CM agencies for different types of waivers was causing confusion. And people did not always know where they needed to go to get that support that they wanted for themselves or for their families. And so what we had heard overall was that creating a system that reduced confusion, was simple to navigate, and focused on quality and accountability for the CMAs was of the highest priority. We also heard that people said they cared a lot more about the quality and accountability of their case management agency than they did about having a myriad of options for their case management agency. So with that in mind, we spent significant time looking to other states' models of case management. Again, these models did not directly compare, but we wanted to look at what was out there. And with that, we did take some ideas away, but what we ultimately found, and sort of what has informed the entire conversation, has informed the drive of this process and of this project, is ensuring that we have accountability and quality. And that with that, we are focusing on the individual, we are focusing on the person-centered nature of these services and what needs to happen to ensure that people are held accountable in terms of case management, but also have the flexibility and ability to build those relationships that are so important to this service. So our vision is a system that we no longer separate members based on their disability, but rather discuss the needs of each individual and serve each person as a whole person. And that each individual is served to experience case management that embodies simplicity, quality, stability, and accountability in a conflict-free environment. So, with that, we had several key outcomes, 5 to be specific. These really informed the particular areas of focus that we had during this entire conversation, during this entire process. So first and foremost, federal compliance. We wanted to develop a case management system that follows all federal requirements, including that there is conflict-free case management. We wanted to ensure there was quality, develop a case management system that is rooted in quality with an emphasis on measurable performance and measurable outcomes that we ensure drive success overall and meet the needs of that individual. We also wanted to ensure it was simple. Again, having those 3 different entities that currently serve waivers was confusing to people. So we wanted to develop a case management system that is easy to access, efficient for our members, and provides members with the tools they need to navigate the system as easily as possible. We also wanted it to be stable. We did not want a lot of disruption or differences or different organizations leaving the agency. We wanted that stability to ensure there was the access to care that people could expect. They knew where to go. There wasn't a lot of change within that system. And then finally, and I think very critically through all of this, we wanted accountability. We wanted a case management system that valued transparency, and its responsibility to its members and stakeholders was expected and was able to be accountable to everyone who was within the system. So as part of that, and I'm sure many of you have seen this before, the department developed a house model. We can go to the next slide. There we go, thank you. What this does is really illustrate the expectations of case management. Really, the house is intended to show all of those services that are rendered to individuals, all of those services that people have access to, all of the work behind the scenes that case management does on behalf of the individual, on behalf of the organization, to make sure that they're serving that member their family, and the community. And so at the center of all of that is person-centeredness and standardized training. As you can see, that has to be throughout. There has to be a very high bar there that speaks to person-centeredness throughout. It also includes intake and eligibility, outreach, so working with different organizations, working with different community advocates, community nonprofits, for example. It also has ongoing case management functionality, so the service planning, the monitoring, making sure if someone's situation or needs change that there are revisions there. And then last, it needs to include those administrative functions, so waiting list management, for example, for our DD waiver, human rights committee, appeals, looking at our state general fund programs. All of those things need to be inclusive of this particular model. And that's why we built this house, so to speak, that captures all of those things as part of this process. In terms of case management redesign specifically, if we could go to the next slide. This is the framework. This has really been probably a slide that many of you have seen before. This has really been what has driven the process. That in the house slide really allow for people to see what the intent is. Put frankly, it's a new structure. It's knowledge, making sure that we have training and support for agencies to serve everyone. Conflict-free, it has to be conflict-free, both because of the federal requirements, but also because we know that those outcomes are best when we do have that conflict-free type of service. And then finally, we need to ensure there's accountability. And you'll notice that we've had that slide quite a bit, making sure that we know and have those metrics to go out and look whether or not there is a case management agency that is underperforming, and being able to target training, being able to target work around that to ensure that we can meet the needs of individuals in their community. So as part of that, we need to ensure the different mechanisms we have to help build this new model, help build all of the work that we're doing around case management redesign. So there's the new assessment tool, there's the new person-centered budget algorithm, and then there's an entirely new IT system. So for those of you who are familiar with the case management system, it's getting away from things that have been around for decades, the benefits utilization system, or more fondly called the bus. Things like that are changing and will allow us to catch up in the 21st century and have those new technologies where there won't be such an administrative burden on sometimes members, but also case managers and other individuals within the system. But not everything is changing, and we want to make that clear. There are some things that we have, like I said, that are uniquely Coloradan that we want to focus on as we do go through this process and as we talk to you all. We could go to the next slide. What is not changing? Access to services. No change to this whatsoever. Current services are and will be available the same way as they are today, and will be in 6 months to 6 years. Nothing around that has changed. Second, we continue to be committed to a person-centered approach to case management in HCBS. So we will not be changing any of that around the person-centered approach. We will ensure that the individual is kept at the center of all of that work, making sure that the individual has choice, is given those choices appropriately, and has the ability to really cater their service package to the needs of the community, to their needs within that community. We also know that there will still be case management. Case management is still there. It is still at the core of how these services are developed and individuals are able to access them. So that is not changing. And then finally, local knowledge and expertise is not changing. We are not intending on making this some type of system in which people are sort of taken out of their community and don't have that connection. So you're getting a case manager who maybe isn't familiar with that area, or familiar with different service agencies in that area, or what community programs or nonprofits may be available. So all of that is remaining the same. And we know that that local springboard of knowledge is really key to how some of these very successful case management agencies are able to successfully operate. We will ensure that will continue. And so again, a very quick high-level overview of what we're going to cover today and sort of how we got here. I'm going to turn it over to Amanda for one more slide in terms of the overview, and then we'll answer some questions.
Thanks, Colin. Great job. I really appreciate you laying the background and providing that information. You did a great job. Here, as Colin, walked through that, you can see there's a lot of different moving parts to case management redesign. And so on our website, on the case management redesign page, we have this interactive timeline to show where we're at today and the timeline for the rate analysis and the rate work, when we're going to be developing and where we're at in the progress around quality measures and developing those metrics, along with training. And then to be able to operationalize this, we have to seek several different federal authorities from our CMS partners. And so you'll be able to see on the website, and I keep referring to the website because it is interactive. You can actually click on it and it will have a pop out and give a little more context and information. Some of you are involved in our current rule and regulation, stakeholder engagement, where we're taking comments and feedback. And you'll see here the timeline for that, as well as the new contracts and the member updates. So just want to always make sure that you're aware of the timeline and where to find that. So if we go to the next slide, actually would like to, I see there's some questions that have come into the chat. And so Hannah, thank you for your question around, in the house model. Is it the same way? Will case managers be doing it their own way, or will there be some standardization specifically around annual service plan prep and revisions? And so throughout all of this, one of our key goals is really accountability. And so we're trying to create that balance of having standardization so there's consistency statewide, but also allow for some flexibility that meets members' needs. And so we going forward will have, I think, tighter rules around expectations and standards, but also try to blend that balance of making sure that there's always an exception or an opportunity for some local level or regional level flexibility. The next question I see is, will Social Security determinations be at the county or with the case management agencies? That will remain at the county with the contractor. My apologies, I don't remember what the acronym stands for, but Arbor is the contractor that does those. And the reason why we have that showed on the house slide is for oftentimes that is a component of how people access services, and it is separate and apart from case management agencies, but it contributes to their roles and responsibilities because they can oftentimes help individuals navigating that process, which at times can be challenging. The next question is, where will CFC fall in the house model and who will manage these services for members? And so there's a lot of work happening and underway with CFC. And so we're working through all of those logistics, but I think for us, what we're trying to do is simplification. And so similar to how case managers assist with prior authorizations and support planning, I would expect there to be a role for case managers with the CFC process as well. We just haven't finalized those details. And for those of you that are asking what is CFC, my apologies. It's Community First Choices, and it is a state plan benefit for personal care and other specific services to really meet people's needs in the community. And there's a really robust stakeholder engagement process in there. We can probably drop some more information in the chat about that.
Okay, thanks, Annette. This is John Barry. I'd like to see if anyone would alternatively like to ask a question or make a comment verbally. You can do that by typing your name into the chat on for the queue, for example, or you can raise your hand in the webinar. Again, that's the reactions button on the bottom of your screen. Or at this moment, if you want to make a verbal comment, you can give me your name right now by unmuting your phone or computer audio, *6 on the phone. Anybody give me your name? Okay, hearing none for the moment. I see Someone named Zoom user has raised their hand. Thank you. Please go ahead.
I think that might be me. My name is Ingrid Colstow, and I'm a parent caregiver. Bravo on all of the legwork that you guys are doing. I know that this has been really hard, and I know that there is a lot of people, what I can hear from the groups that I'm in, all of us that have kids with disabilities that are on waivers, everybody seems to be really affected by choice. So they keep being worried that all of a sudden, because unless you have a child with a disability and you have to go through all the paperwork and all the legwork to try and get them on the waiver, when people start talking about, oh my gosh, it's going to be redesigned and taken away, everybody starts to sort of freak out because they think we're going to lose our benefits. So I think what I heard from your slideshow today, and I just want to make sure that I give the right information back to the community that I'm in, is that nothing is going to change for the benefits really that you're getting. The only thing that's happening is that it's being redesigned so that it's more efficient, in compliance with federal law still. The quality is better, and you're going to have a more child or person-centered experience. The other thing is that I have heard people worried that they're not going to have as many choices. And so choices of case management and point of contact. And in my group, we have a really great company that we work for, and we're just wondering, is that company going to disappear? And so we will inevitably end up having to redo everything with someone new. So maybe you can speak to the transition that way. So I'd be interested in knowing how many organizations you think you're actually going to lose and downsize to, and how you're deciding who's going to remain as a case management companies, and then how you're going about that. So am I right on what I took away from you first? And then the second part of that question is, do we still have choice?
Yes, thank you for that answer. I think Colin will speak to benefits. I would say that was a beautiful summary.
Yeah, no, that was great. I might write that down and just use that from now on, Ingrid. That was fantastic. So yes, I think you absolutely nailed it in terms of that summary. I think in terms of services, yes, 100%. Those things will be moving forward. And when we say redesign, what we're talking about is never taking away choice. What we're looking at actually with CFC, or Community First Choice, like Amanda had talked about, is actually an expansion of our participant-directed benefits. So that will mean now, once we move forward with this in several years, we will be able to have children that can access our consumer-directed attendance support services benefit, or CDOS, as we refer to it as. All waivers will be able to access our in-home supportive services. It will expand choice there. So in terms of benefits, none of that is changing. There's no reduction in choice ever as part of this process.
And thank you. And I will talk a little bit more about how we will select the case management agencies going forward. One of the things I want to share, when we were doing our work over the last 2.5 years to really look at best practices in case management, what's working, what's not working, how do we really put forward a Colorado solution that makes the most sense? Some states have literally opened up case management to any qualified provider, and then there's hundreds of them. And when we go back to what the core goal around really trying to have consistency and quality in case management, the states that went that direction are actually now in the process of changing it, because they found that they weren't getting quality outcomes, and it was very difficult to navigate hundreds of case management agencies and then hundreds of service providers. And so what we are trying to really do is simplify that at the case management level so that you can really focus on your choice in providers. And so I think that's a really great segue to the next section around case management agency selection process. Before we get there, just to talk a little bit about the defined service areas, though, in the future where we'll have single case management agencies serving all people, regardless of their disabilities, within their contracted case management area, or what we're calling defined service area, It took us about a year and a half of work to really work through this process, because currently for our single entry points, we have 24 catchment areas. And with our community center boards, we have 20 catchment areas, and they don't align. So they're different. And then we have, as Colin mentioned earlier, our 4 private case management agencies that serve our children's HCBS waiver. Those are statewide organizations. And so we went through a robust process to really look at, as we implement case management redesign, we have to consolidate those catchment areas. And so we gathered information from stakeholders. And it's funny because I look back and it's been 2 years ago now. We kicked that process off in November of 2020, where we really looked at, in addition to what was important to individuals through the stakeholder process, really geographical barriers. Are there mountain passes or large travel distances? What is the total size of the geographical region? And also to look at economies of scale. How do we make sure that the case management agencies are successful, and that there's a business model to really support that sustainability, because stability is very important for us. And then population density, really making sure that we looked at the total number of members in each of the specific geographic areas. And in addition to this, we also had a contractor help us really look into this and each of those 3 components that I mentioned. And then we did stakeholder surveys, electronic surveys, and had really good response rates, and then listening sessions to really inform these 20 new catchment areas, which we are now calling defined service areas. So these defined service areas will go into effect July 1st of 2024. We estimated future population growth to also include some portability, which we'll talk a little bit more later within those catchment areas. We looked at new enrollment growth forecasts taking place between now and 2024, as well as really trying to align with county boundaries the best we could, so that we could try to ensure that people aren't having to navigate multiple geographical boundaries. So that really was the work that we did around the defined services. And on our website, this map is actually on there, so you'll be able to find that. And then to answer the question and move into, well, how are we going to start selecting case management agencies for each of these defined service areas? If we go to the next slide, in order to select one case management agency in each of these defined service areas, the department's going to go through a competitive request for proposal, or what we oftentimes refer, or you will see, an RFP process. Anyone is welcome to apply, and we expect that there will be existing case management agencies and even new case management agencies that will apply. This is a very prescribed legal process wherein applicants will submit their responses, and the department will convene an unbiased committee to review and determine which case management agency is best suited to serve each area. So again, because of the formality around this process, at times the department has had to be very careful about, when and what we say, because we can't divulge information that will be in that RFP prior to its release. But what we can talk about is the process. So if we go to the next slide, our legislation that was passed, House Bill 21-1187, requires the department to create a singular case management structure that will result in one contract for all of those activities listed in that House model. And so I think that's where the visual that shows each of the activities case managers will do, the case management agencies will be required in their defined service area to provide all of those services. Our state procurement law prohibits the department from releasing any specific details that will be contained in the RFP, as it would be considered giving a potential offer an unfair advantage to have information that is not available to the public at large. We are required to have the RFP posted no later than December 31st of 2022. And so that is just a few short weeks away. And so we are working fast and furiously to have that happen. The department anticipates that potential offers will have 8 calendar weeks between the posting and the proposal submission to be able to respond. By law, we are also required to have an inquiry period. And so this means that it will allow each potential offer an opportunity to ask questions related to the information that is listed in that request for proposal. We anticipate that offer inquiry period will last about 10 business days. And then the department will have about 7 business days to be able to respond publicly and make all of the responses available to all of the offers. And then we will have our evaluation committee review all of those responses, and we expect to publicly notify and do notice of intent to awards in May of next year. So May of 2023 is when we will know who the future case management agencies will be. Once the RFP is posted, all questions regarding the RFP will have to go through our procurement team, and there will be an email address available that's listed in the RFP so that people can send their questions to them. I think that, this is always a hard one because of just the structure and the process around this, but it's really intended to protect the integrity of the RFP so that we don't have appeals or litigation around awards. So I think that sometimes can make it a little bit challenging to navigate around just asking questions specific to the RFP, but there really is a process intended to protect that. So then one of the pieces, if we go to the next slide, when we were working on House Bill 1187, we heard resoundingly from our stakeholders the importance of having stakeholder involvement in the RFP process. And so we said we would take that back and really dig into it and figure out a best path forward that will blends that balance of protecting the integrity of the RFP, but incorporating feedback. And I'll just be really transparent and honest, that's a tough one to be able to make sure that we are incorporating all of that. And so I think we've come up with a really good solution that incorporates a broad perspective to be able to incorporate that feedback. And so what we're going to do is put out a survey the day after the RFP is released for stakeholders to be able to respond to about what you're looking for in your case management agency. And then we'll take all of the feedback that we received from this survey and create a criteria for the review panel to be able to use to make a decision about which agency is the best fit for the case management agency in their area. The department's doing our best. We will to get that advertisement out about that survey because it's really important that we get feedback and responses. And so my ask of you all today is please join us in getting that word out. We will have a condensed timeline for that survey to be open. So as I mentioned, there's tight timelines around that. We anticipated about a 2-week period. We heard from some feedback that give us more time. So we're trying to get about 3 weeks to have that survey opened so that we can culminate all of those responses and put together that criteria for the review committee to have. We will then publicly notice that criteria so that it is available for everyone to see. So I'm going to pause there about the selection process, the RFP process, and the stakeholder engagement and involvement with the RFP. So open it up for questions.
Great, thank you, Amanda. This is John again. So let's start with any verbal comments this time. So you can raise your hand in the webinar if you want to give a comment verbally. You can type your name into the chat, John for the queue, for example. We're also going to be going to written comments and questions. Anyone? Okay, Jen, have your name. Oh, thought there was a Jen up there. I think maybe she changed her mind. Gina. Well, Jen went first, I believe. Jen Oakes, please go ahead, then Gina will get to you. Jen?
Thanks, John. I just wanted to ask, are you thinking around December 22nd is when that survey will be out?
Jen, thank you for that question. We are expecting the end of December. So I would say after Christmas, but before New Year's Eve.
Thanks, I just want to have it on a radar.
Yeah, thank you, Jen.
Mhm.
It's great to see you, by the way.
Thanks, Jen. So now we'll go to Gina Bruckner.
Hello, can you hear me?
We can.
Yes.
Okay, wonderful. So my sister was in the program about 7 years ago and got hurt. I was having a hard time with managing her. And so we closed out her case and she went into a facility for a while, but now she's out into the community again and really struggling trying to get a case manager just in general. And is there something what can I do? How can I help her? Because I can't manage her healthcare this time like I did several years ago.
Yeah, thanks for that question, Gina. We will put in the chat our case management team's email, and you can reach out to us and then we'll follow up directly with you and work with you on that.
Oh, that would be such a relief. Thank you so much.
Yes, thank you.
All righty.
Thank you. This is John. So let me John Barry, check in with Tiffany. Are there anything from the chat you want to go to at this point before we go to the next verbal comment?
There are quite a few questions about the panel for the RFP. Amanda, do you want to talk about how the panel is pulled together and then reemphasize how the survey will be used?
Sure, thanks for that. So in terms of how the panel is selected, we will have department subject matter experts across case management, benefits, our RAY team participate in that panel. We expect it's going to take the panel members about 20 hours a week for 10 weeks to work through all of the responses. So it is going to be a significant lift for those individuals participating in it. And then the survey that we are asking stakeholders to complete, they will align, the questions in the survey will actually align with some of the RFP responses. And so we'll gather the feedback from stakeholders about what is the criteria you want to see in your case manager, and then we'll provide that to the committee members to look in juxtaposition to when they're reviewing the proposals and making a determination. And so part of what we were, because of the significant amount of work it is for the review committee, and also making sure that there's the confidentiality around the proposals through that process, we felt like this was the best path forward to make sure that we were able to incorporate the feedback and what is important, while also having the department staff working through that.
Thanks, Amanda. This is John Barry again. Are there any other comments from the chat, Tiffany, that you wanted to address before we move back to verbal comments?
Let's go ahead and move forward with verbal comments.
Okay. KM, you're up next.
Hi, John.
Who that is?
It's Kelly Morrison from Weld County. And Amanda, I've asked this question before, but I've never gotten a clear answer. Are you able to share with us for each entity that's applying, how many areas they're able to apply for in the RFP?
Yes, Kelly, I appreciate that answer. So this goes back to, the department. There are some things that we have limitations around what we can share prior to the RFP being released. I've publicly shared that the department is looking at having a limitation on the number of catchment areas or defined service areas. We are still working through that, and it will be part of the RFP.
Thank you.
You bet.
Okay, thank you. This is John Barry again. We have a number of hands raised in the webinar. We're trying to balance the time, needing to wrap this at 9:55 and move to the next slide. We'll get through as many as we can, folks. Tom Whalen, you're up next. Okay, we will come back to Tom Maureen.
Oh, we can hear you now,
you're there,
Tom.
Sorry, I apologize. I'm having a little trouble with the navigation here on this. I'm on my smartphone. My question is, does this actually apply to CDAS or just HCBS in general?
Great, thanks, Tom. So for individuals who are receiving CDAS services, they do have a case management agency that they work with. And so for the case management pieces in terms of the assessment and the support plan and the prior authorizations, that all is through the case management agency. And that is including those whose benefit services are CDAS. So yes.
So I mean, well, I'm in Pueblo County. And Department of Human Services is my case manager. So will that stay the same?
So in May we'll know for Pueblo who the awarded case management agency is. And then once we have made those notice of intents, we'll communicate out with everyone around if their case management agency is staying the same or changing.
Yeah, because I like I said, I'm a little naive. I had a webinar with an agency at Denver, Colorado Cross Disability Association, and they had a webinar on this still. And I reached out to my local folks here, and they're still pretty naive. They've heard glimpses, so nobody's even locally has a clue really what's going on. That's why I'm trying to gain as much knowledge as possible.
Yeah, I appreciate that. I think it is a tough place to be in because of the competitive request for proposals. We don't know who's submitting to that. And then, we don't know who will ultimately be awarded yet. So a lot of that clarity will be next spring. We just want to make sure that everyone understands the changes that are happening because there's a lot and we don't want people to be surprised.
Because I don't, there's no conflict between me because my case management, the local Department of Human Services doesn't provide services. My wife and my caregivers provide the services, so there's no conflict there. So that's why I was wondering if it applied to CDAS as well as folks that are getting help through an agency per se.
Yep. Well, thank you for that, Tom, and we'll let everyone know after the May. Yep.
And when do you think this will go live? I'll leave you alone, I promise.
Oh, no, that's okay. So we will fully implement Case Management Redesign July 1st of 2024. And so we have about a year and a half.
Okay, so there's no big changes at all till July of 24.
We may have some agencies transition a little bit sooner, just to manage the change so that it's not everyone at once. But yes, we have time and nothing is changing today.
Awesome. I just thought it was odd. My local county didn't have more knowledge on the what was going on, so that's why I didn't know if it would even pertain to me or not. But thank you for your information. I appreciate it.
You're welcome, John. Or Tom, John?
No, that's fine. Thank you.
Thanks. This is John Barry again. So I see Maureen and Jerry, and please, if you can help us, we'll get through both of your comments in a couple of minutes if we can. We need to move forward. Let's start with Maureen Welch. Thanks, Maureen.
Hello, this is Maureen. Can you hear me okay?
I can. Good to hear you from you, Maureen.
Yes, so I was a member of the, excuse me, 2014 Case Management Task Force back for conflict-free case management in 2014. And I joked then that it would take 10 years for this to come to fruition. And it looks like that was sort of an accurate prediction.
Good crystal ball.
But I do want to comment that I'm extremely disappointed with how this rolled out. It basically has eliminated and hijacked the concept of independent case management, where we could have small niche agencies that specialize in, specific needs for members in Colorado. This is a boondoggle for the community center boards, who are going to become the Walmarts of Main Street and put everyone out of business and basically allow no one the choice except for Walmart. So I know you've all heard this, and I'm very disappointed. I don't like what's happened, but even with all the service and volunteering I do, it seems that the interests of the community center boards, including, different people in leadership at HCPF, have influenced this whole process. But the one amount of choice that I think I have a question about that even appears to be in jeopardy under this new mega Walmart system is the choice of case management agencies. Currently, I use a community center board who is outside of my catchment area because of many conflicts of interest that I had with my assigned catchment area community center board. And I read in a proposed rule document that you may be limiting or even eliminating that option if a member could find a willing and able case management agency to serve them, that may not be a possibility in the future. Really, I can't choose. You're eliminating independent case management, and now there may not even be a choice. This is really, really not at all the initial intent of the final rule coming from the federal government Center for Medicaid and Medicare Services. So I'd like to get an answer on choice of the case management, if there is any left. Thank you.
So thanks for that, Maureen. We actually, the next section is on portability and the grievance process that specifically addresses that. But the answer is there will always be an exceptions process. And we'll talk a little bit more about that in the next area. And I'll just offer, I appreciate your honesty with the group. And I hear you. I think, I worked in a state where we had lots of choice in case management agency, and I worked really closely with the advocacy community and navigated the challenges and barriers that met. Like, I don't think there's ever going to be a one solution that meets everyone's needs that's perfect. I think it's really trying to strike the balance of how do we minimize, having to navigate multiple entities based on a disability or who serves what group, or
right. So instead of
having for us at the department, excuse me, let me just finish for a second. I really want to drive that, it's really important for us to have quality oversight, and our ability to be able to do that in the future state was a goal of ours. And trying to create a broker system that added another layer for individuals to go through was complicated. And so I hear you. Is this going to be a perfect system come 2024? No, but it gives us the framework to really build off and move forward. So from that, I think let's go to portability and grievances.
Amanda, there was a rule change that I read about recently about limiting it. So I want to make sure we address that. Thank you.
Yep.
Amanda, can I just really quick, less than a minute, I want to comment on Maureen's comment and your feedback. I'm just hearing this glaring concern where there's this significant support community, meaning complex medical needs. We've got followed by 28 specialists at Children's Hospital. We've got 85 hours a week of IHSS. There's this certain population that needs that attention that I know from early intervention and FSSP, that at CCB, the best that they can do, they can't meet those needs. They can't give it the attention they need. So is that something you're going to speak to in this next section?
Yeah, I appreciate that, Abby. I think, one of the things that we heard really loud and clear was the need for training. And I want to clarify that the community center boards are not guaranteed contracts. They are part of this process and the team. And so I just want to dispel that myth there. Similar, we have single entry points out there that are currently providing these services. And so to your point, Abby, one of the things that we need to make sure that there's that specialization and really solid training for all different populations that our programs serve. And so we, at the very last section, we'll talk about, what the department is doing in terms of readiness for case managers around training and making sure that they have the tools and resources that they need so that they can really serve, whether it's complex children, medical needs, or, different populations.
Okay, this is John Barry. We have one more try to get in here before we move forward. Thank you all. Apologies. Jerry Froney, please go ahead.
Sorry, Jerry.
Yes, I'll be quick. I really strongly object to the panel choosing CMAs, not including at least 2 advocates. We can't assume that interested folks would not have 20 hours a week available. And I'm strongly insistent that HICPUP consider adding at least 2 advocates to that panel, because without that, there's going to be all sorts of suspicion about how CMAs are selected. And you need to have a transparent process, and that would be at least one way to do it. Have a minimum of 2 advocates on the panel. Thank you.
Thank you for that feedback, Jerry. It's certainly something that we have worked closely with our procurement on, really trying to find the best path forward on. And so I appreciate your comment.
Yes, thank you, Jerry. So we need to move forward at this point. Thank you.
All right, thank you, John. So in terms of portability, currently the way portability works, and what does portability mean? Let me start there. It's really moving between case management service areas. And when there is that movement, being able to retain or keep your current case management agency or case manager. We typically see this in the community center board community, where individuals have more fluidity and movement, and not as much in our single entry point. As typically what will happen is somebody will transfer from their current case manager over to the case manager that is serving in that new region where they live. So when we think about future state and what does this mean and what does this look like, if we go to the next slide, in the future, with case management redesign, members who move between neighboring case management agencies service areas will have the option to continue to stay with their current agency. The case management agencies will be required, though, to have a policy and a procedure to allow for this, because we want to make sure that across the state, everyone has this in place so that there's some consistency, but we also want to allow for some flexibility at the local level. The department will have oversight and review these policies to make sure that there is that consistency, and just need to make sure that the case management agencies have the appropriate staffing to be able to support the members. I think that this is really important to us because we know people move, and that there is changes on a regular basis to meet individuals' needs, and that there is some kind of interesting geographical boundaries around the state. I live in South Jefferson County, and if you go a mile up from my house, on one corner you're in Denver County, the other corner you're in Jefferson, and if you go a mile south, you're in Douglas County. And so we really want to make sure that individuals have that opportunity, so they're not having to not only change service providers, but also case management agencies to allow for that fluidity at the local level. We also want to monitor this though closely, just to make sure that we're tracking better the number of individuals who are being served outside of their service area, just so that we can make sure that the structure of the case management agency really supports the enrollment and the number of members that they're being served. I think portability is different than if somebody wants to switch case management agencies due to quality or their ability to work through some challenges with that case management agency. And so in response to that, we'll have a process as part of our grievance and complaint process. And so if we go to the next slide, our current grievance process, it's pretty vague in rules, what the requirements are. Case management agencies are required to have a process, but it's not always clear or made public or apparent to members when they have complaints. And so they are required to report to us annually the number of complaints and grievances they receive. But in future state, we want to make some changes to how this actually works. And so if we go to the next slide, when we look to the future with case management redesign, the department's wanting to create more consistency and quality around case management. We've heard through our different engagement efforts that it's very important for that consistency, but also that there needs to be some transparency around grievance processes. And so we are going to require community advisory council for each of the defined service areas, so that at the local level too, that there's involvement and engagement and understanding around the quality and the grievances and complaints that are coming through to each agency. It's our goal to have more transparency around those processes so that they're publicly available and that members are notified, and it's really clear for them when they are having challenges or difficulties how to navigate that. In the event that a conflict cannot be resolved at the local case management agency and it's escalated to the department, there will be an exceptions process that will allow members to be served by another case management agency. So I want to, the earlier question of, if you have challenges with your case management agency and you're not able to address that, or if you're staying with or moving a service from one service provider to the other, can you stay? The answer is yes to both of those questions. And so I'm going to pause here and go to John to see if you have questions.
Thank you, Amanda. So this is John Barry. So regarding this last section that Amanda reviewed, excuse me, any questions or comments, you can raise your hand in the webinar using the reactions button. You can type your name in the chat for the queue, or you can unmute your computer or phone right now, *6 on the phone. Give me your name and I'll take your name at this moment. Anyone? Okay, I see one hand raised in the webinar. Anyone else? Select a few names here if I can. Seeing no new names in the chat. Lots of comments. Okay. Jen Oakes, please go ahead. Thank you.
Yes, I'm happy you have a grievance process, but will there be like a standard resolution process to the grievance? I mean, like, how do we know what's going to happen if we do have a grievance?
That's a great question, Jen. So there will be requirements in the contract And I know the team is working on proposing some changes to our rules that tighten up what is required and spells it out more clearly. And then our hope is that then each individual annually would be notified of their grievance process and have access to what that process is, and and clearly informed on how to navigate it when they need it.
Thank you.
Thank you. Kelly, you're up next. Please go ahead, Kelly Durant.
Thanks, John. It appears to me that everything that's being put in place to be able to have any choice is being done after the fact. And we may be in a unique situation, but my CCB, I had a child and we applied for a waiver and we were denied for that waiver because he doesn't sleep through because he does sleep through the night. So when we were denied for that waiver, that was the end of the story. And we went a few years without any services at all. And then I found out about a program where I could offer him services as a parent caregiver. But in order to do that, he had to be on Medicaid. Well, I ended up going through a CMA who helped us with the application process and got us onto the CHCBS waiver. But that CMA is not in my catchment area. And so for me personally, my whole path to all of this started outside of my catchment area. It was not that I was in an area or assigned or had somebody and I chose to leave or I moved areas or anything like that. So I want to know, and I know I'm not the only one, I want to know that there's going to be some opportunity on the front end of things for people to make these choices to go outside their catchment area. It may not, and there may be many reasons, like you mentioned a little bit ago, you may live a mile inside a certain catchment area, but the office for the other catchment area is closer to you, or you never know what a family's reasoning is going to be. So will there be some provisions put in place where there will be choice on the front end of this, where it's not going to burden the system and the people to go through grievance processes?
So I appreciate that question, Kelly. And, full disclosure, we're still working through like the process and the rules around how this will work and what that will look like. I think at the point in which we do notice of intent to award next spring, and the notifications go out to members if their agency is changing or if it's staying the same, like there will be as part of that communication, there will be information in there that will speak to what does that process look like and how do you do that.
Okay, thank you.
Yep.
Thank you. This is John again. So Abby, you're up next. Thank you.
Great. Thanks, John. This is Abby Amert, and it's much in line with what Kelly was saying. I want to ask that this audience be very sensitive to the significant support needs world, meaning, like I said, my son has 85 hours a week IHSS, just extra support he requires, everyday tasks. And so I appreciate the system that you're putting in place and the appeal process, the grievance process. I respect it. But I want to make it clear that when we are dealing with the complex children or adults that literally are three people's jobs, we don't have time to go through grievance and appeals. We need people that are, really focused and specialized on the complexities. And I'm talking about kind of a 1 to 5% of all waivers that they have this extensive level of needs. So there's this certain audience that I really am asking that you consider, the significant support group where we don't have time to go through grievance or appeal.
Yeah, thanks. Abby, I'll just share that.
Called
some background. Let me see it, John. Can you help us?
Together, playing all the songs and sometimes representing people from the band, the last concert of the band.
If you're on a phone call, could you please mute yourself? I think we are. Oh, perfect. Thank you. Abby, I appreciate that. I mean, one of the challenges is CHCBS is definitely a very unique program. And so we are continuously working with Colin's team, because of the intersect with the benefits and the specialized services on really putting a path forward. I think, one of the challenges with having it separate and apart from the rest of the system, though, is also that then when the kids age out of the system, then you're, trying to find another case management agency there too. And so, I think I hear you. I'll take it back to the team and we'll have more conversations. But we're really, trying to align and create, I think, just really trying to move away from, you get a certain set of services or rules applied to a certain waiver over the others, because it creates other challenges and barriers as well. But I certainly want you to know that I hear you around, the complexities and just the day-to-day life that you have and this change and the disruption it will have on that.
I really appreciate that, Amanda, and I really am glad you're taking that back, to your team. It's such a big deal. I mean, in my wheelhouse that I manage every day, there's appeals with everything, there's grievances with everything, and the benefits are amazing. I appreciate them, but there's just only so much, that we can do. Hence the nature of the HCBS waiver, especially for the significant ones. I know we have more hours than most, just because of the needs. So just keep in mind that special little audience, as part of this that will suffer, and I can guarantee we will suffer because of just time, just simply capacity. So thank you.
Well, I think one of the things that was very impactful for me when we did listening sessions with family members receiving CHCBS services about a year ago, I think the goals and the things that you all have shared with us around what makes your case management experience really work for you is ultimately what we're trying to create for everyone receiving services. And so trying to really drive that consistency. And so I just wanted to share that because I appreciate that. And I also have appreciated the feedback and engagement that you all have participated in.
Wonderful. And my last thing I want to comment on that is, in my case, our case, we've always been with a private case management agency, not a CCB or an SEC, but that works for our needs, right? And so we've also been in the county system, for example. I know it's not automatically CCB, but with the early intervention and the FSSP program, 0 to 5, my son is 6 years old now, my experience is that those programs, the design, the case management, the training, it works for 90% of the audience, but there's this 10% it just doesn't work for. So please consider that group. Thank you. That's all.
Thank you.
Thank you very much. This is John. I'm trying to keep us moving forward and balance the time. We'll go to Elsa and then Jerry, and I believe we might be moving forward at that point. Elsa, thank you.
Thanks, John. So, I guess I have an observation, a question, and an idea. So the observation is that, I've participated in all the stakeholder meetings, and it has eventually circled around this question of choice. Mm-hmm. And I personally believe choice is a human right. I think it's the single way we keep ourselves safe from circumstances that we can't control is by removing ourselves from them without having to go through a long process. So I think the most important thing in the process of change is to do no harm. And I'm hearing from so many families that harm is going to be done if choice is removed. So I guess my question is, will HCPOF reconsider expanding choice and looking at a certification process? It doesn't mean that has to be, day one, everybody is given a choice. I think, it makes sense to have eligibility funnel through a local entity and then choice be, because I also don't think the broker idea is great. So my question is, will you please reconsider this after what you've heard over and over again? Because we can't move through any of this process unless this issue of choice is resolved right now. So my last thought or idea is if offering choice of CMA is not something you will reconsider, then the grievance process I recommend is an external entity and is not the entity you have a grievance with. And please look at some of the Oregon programs around human rights committees and other things, because it's extremely difficult. You know, if I'm not happy with King Soopers, I'm going to go to Safeway. Case management is a Medicaid service. I don't understand why choice isn't extended just as it is in the choice of other providers, with obviously reasonable, rational structure behind it. And I don't believe that you should assume that quality will be there. Choice is one of the things that will drive it. So, you know, please reconsider.
Yeah, Elsa, I appreciate your comments and the feedback around, you know, looking further into the grievance process. I think that's an interesting one we can take back for sure and look at, you know, when we were talking early on around, you know, the third party broker and transitioning away from that and moving towards, you know, a case management agency for each defined service area. You know, we talked a lot about choice and really, you know, it and in discussing that, talked about, you know, making sure that there are processes, because oftentimes it's about the case manager itself, and making sure that there's a good fit between the individual family and the member and the case manager. And so part of what I think maybe I missed in the last slide was that there will be requirements for case management agencies to also include a process for making sure that if there needs to be a change in case manager, that there is a process for that. I would say at this point, because we are getting ready to release the RFP in a matter of a couple of weeks, we are very committed. It's actually in our legislation to move forward with a single agency. But as you suggested, we can certainly take back the grievance and look at how we might add in some additional protections around that process.
Thanks, Amanda. This is John again. So we'll move to Jerry, and then we will move forward again to the agenda. Jerry?
Okay. Quickly, just in housekeeping, I would like to see the chat available to everybody in attendance, or put it on your CMRD website. But I don't think it's okay for HCBS to say, no, we cannot copy the chat and have it available to people. There's lots of good information in the chat, and it needs to be available to all of us. Thank you.
Thanks, Jerry.
Thank you very much, Jerry. This is John. I will have us move forward, please. Thanks, everybody.
All right, so in the next section, wanted to provide some updates around the CCB designation. You know, currently many community center boards receive local funding based on their organization's mission to support and provide services to individuals with intellectual and developmental disabilities in their local communities. This funding has historically been tied to the community center boards and is something that the State Department of Healthcare Policy and Financing does not oversee or administer. But we are very sensitive to the fact that that at a local level, there is a tie to the CCB designation that the department provides to these organizations. And that actually in some areas of the state, the CCB is named or required in their voter approved ballot initiatives. And this is a significant amount of funding at a local level that is made available to really meet individuals' needs or unmet needs at the community level. And so we have been committed to really working with our partners to find a solution that does not interrupt or negatively impact funding. So we have created a future community center board designation that is very separate and apart from the case management agency contracts. We will be authorizing the CCB designation for a 10-year period. There will be no direct services for case management activities tied to the CCB designation. So it really is more of a designation in name to protect those local dollars and resources. The CCB areas will stay the same. We will not be changing their designation areas. Again, I just wanted to share that, the department does not have oversight or jurisdiction of these fundings. And so there will be a very limited oversight from the department's perspective of the CCBs, because our oversight will really be for case management agencies and contracts. So if we go to the next slide, Organized Healthcare Delivery System is a program that has historically been available only to individuals receiving intellectual and developmental disability waiver programs. And in the future, we will have case management agencies acting as the organized healthcare delivery system and be responsible to purchase the items and services that are listed below when a willing and qualified provider is not available in a case management designated service area. The CMA or case management agency will become an enrolled provider and submit claims for reimbursements based on these prior authorizations. The case management agencies will be required to purchase these goods and services at a fair market value. They must have a conflict of interest mitigation strategy in place, and they must ensure that vendors are certified and authorized by the case manager to act as the organized healthcare delivery system, or OHCBS is the acronym. This new function will be added to the case management contract, but be made available to all members under all waiver programs. So it will no longer be limited to just individuals on our IDD waivers. The services that are being proposed, and I say proposed because this is subjected to CMS approval, is assistive technology, specialized medical equipment and supplies, vehicle modification, vision, and recreational fees and passes. So there will be more information in the future about organized healthcare delivery system, but just wanted to make sure that we share this with you all. If we go to the next slide, Human Rights Committee, we currently have a Human Rights Committee, and the Department of Healthcare Financing and Policy is requiring the community center boards to operate to protect the rights of members with intellectual and developmental disabilities. The HRC act as a third-party mechanism to really adequately safeguard legal rights for a person receiving services by participating in the granting of an informed consent, monitoring any suspensions of rights for a person receiving services, really monitoring behavioral development programs in which individual with intellectual and developmental disabilities are involved in, and then monitoring the use of psychotropic medications. They also review investigations of allegations of mistreatment individuals who are receiving services and supports. And so for future state with case management redesign, I want to be really clear. We are not expanding the HRC to all waivers. It will continue to be for individuals receiving the RDD waivers, but HRCs will move from the community center boards to case management agencies. The composition of the committee will be similar, and the department will use the rule process to clarify roles and responsibilities for the committee to make sure that the dignity of risk for members and the HRC committee members really understand kind of the role and how to safeguard their rights while also allowing that risk. And so then the department will require the use of universal documents to help with consistency across the state. There has been a very robust stakeholder engagement group that has met for at least a year and a half now to really dig into this and develop some consistent forms to ensure that somebody's experience across the state is similar. And then the department will look at how we can improve this process over the next several years. But we also want to make sure that with all of the changes that are going on, that we have some stability around some of the current processes that are in place. So small changes here, but we will continue to work on this. So I'm going to pause here and see if there's any questions before we talk about quality and training and rates.
Thanks, Amanda. This is John again. So I'm collecting names now for the chat, for the queue. I mean, you can type your name in the chat. You can raise your hand in the webinar with the reactions button, or you can unmute your phone or computer, give me your name right now. See one in the webinar. Any names? Okay, and one in the chat. I'm hearing no one unmuting and giving me their name. So we will start with Kimberly. Please go ahead, Kimberly.
Hi. I think in the beginning, the first guy who was talking, I apologize, I think it was Colin, is his name. He kind of went through and gave a whole summary, and that was really helpful. I guess my question is the one choice, the one entity, because yes, I know everybody keeps coming back to that, but it sounded like that was a Colorado state legislative order. And I would like, so is that correct? That it was, it's a governor mandated or state legislative order that it has to be only one agency per catchment area?
Yes, thank you for that, Kimberly. In 2021, there was legislation. It was House Bill 21-1187 that required the department to create new defined service areas and then go through a procurement process that would select a single case management agency serving all populations for long-term services and supports no later than December of this calendar year. So yes, that is correct.
So if we as families wanted to change that, we would have to petition to the state legislature and the governor to have that be changed.
Yes, I mean, legislation is currently in place and for us to implement.
Okay, and then I do want to piggyback on what Elsa said, and I think she brought up a great idea, and that is that the grievance process, and the other person, I apologize, I don't remember her name. It's true. I have 2 special needs kids. I have tons of hours, almost as much as her, or if not more. We deal with appeals all the time. So the grievance process is going to not be great for us. I suggest that maybe instead of trying to go through the case management agency for grievances, that maybe it's just we have an open choice between catchment areas within, maybe it's 100 miles, maybe it's, whatever, 200 miles, but that you don't necessarily have to go through a quote grievance process, or it doesn't have to be a lengthy one, because what my grievance would be might not be as serious to HCPF or the case management agency, and they just kind of keep pushing me aside. So I think I understand it's legislation. So maybe at this point, through that grievance process of just saying, you know what, if you're not happy, you can make it known to the department, you can make it known to your case management agency, but also you have the right to just leave and find another one of those case management agencies, maybe in a different catchment area.
Yeah, I appreciate that, Kimberly. And I think, one of the things I would just like to offer, just because I think Abby's had really good points. And, we've heard from, families with complex kids, medical situations, just the complexity. And, I think we can, separate and apart from this, I think I would like to do a more intentional listening session discussion so that we can unpack, because CHCBS is unique. And I think there's a couple moving parts that I think hopefully will also be important components to the conversation as we dig into it more. And Colin, I think you certainly maybe want to jump in here and have some additional insight.
Yeah, thanks, Amanda. And thank you, Kimberly. That's a great point. And I think well made. And thank you for saying my name correctly. As you can imagine, it gets mispronounced quite a bit. But I think I'm hearing you and Abby really clearly. And when we're talking about kids on CHCBS, especially those with complex needs who are involved with an agency and typically using IHSS, I think there's some additional work that we need to do around that, to build a structure to make sure that those kids and their families and parents, and a lot of them being caregivers themselves, are supported. So what I think I'm going to do, and I've got an email drafted already based on Abby's comments, and I'll certainly incorporate your comments, is I think we'll maybe have a targeted listening session to Amanda's point, but we also need to make sure that it's incumbent on our agencies and the system itself to really make sure there's good communication back and forth. So I think we're happy to start that conversation and really begin there to understand how we can make sure no one falls through the cracks.
Okay, thank you. I also have just one little question that goes back to the survey, and that is, how are you sending the survey to, quote, stakeholders? Because the only reason I knew about these meetings was because of my case management agency, but also I signed up on the website to get emails. I know there's lots of families that don't know about these changes and don't know that it's happening. And so they might have experiences with the potential case management agencies that you're not going to hear from them because they don't know about the survey. So I was just wondering how you plan on getting a survey to every family that is under these waivers.
Yeah, thank you for that, Kimberly. So we, typically for like these meetings, we put it out through our constant contact, and we know it only goes to a limited number of folks. So we're working with our Medicaid operations office, who has for somebody who has an email as part of their Medicaid, we will be sending out through those listservs to really, I think, broaden the number of individuals that we reach from the department. And then we'll be asking our case management agencies to help get the word out.
Perfect, thank you.
Yep.
Okay, thank you. This is John Barry again. So we had Jenna, you gave her name in the chat for the queue. Jenna, go ahead.
Thanks. I just have a really quick question. A couple slides back on the OHCDS slide, it said that the CMA would do this function, and I just want to clarify that that is true. Starting July 1st, 2024, the OHCDS function will change from CCB to CMA.
That is correct.
Thank you.
Thank you. So let me check in with Tiffany. Anything from the chat you want to go to before
Yeah,
we
there was a
continue with
question about timeline. So what is the timeline for these streamlined statewide HRC proposals to take effect? Is it in alignment with the rollout of June 2024? That's from Travis Wilson. And Travis, in answer to your question, all of these changes will take effect with the start of the new contracts for case management agencies that will start in the transitions will start in August of 2023, with new contracts being executed in November 2023. And we will do a kind of rolling transition process through the end of that fiscal year, which is, as you pointed out, June of 2024. So all of these changes will be in effect by July 1st, 2024. And John, I will hand it back to you.
Very good, thanks. Elsa has raised her hand in the webinar. Elsa, please go ahead.
Hi, I just wanted to go back to the person who asked the question as to whether a statute change would be needed. And I recall the process, and I'm, obviously I can't speak to the law, but what I recall was that the initial strategy was to allow a case management agency to be a service provider agency, but just not to the same person. And my understanding is that statute came into effect, and HCPF initially went down that road until doing, having a change of mind and deciding that really what we needed was to have this complete separation. So what I would suggest is that, go back and have a read of that statute, maybe have an attorney take a look at it, because my understanding, it was written to permit a case management agency to also be a service provider as long as it wasn't to the same person. And I agree that would have been somewhat chaotic. So my point is that statutory changes may not be required.
Yeah,
it was at a recent rule, when we were talking about rules at a stakeholder meeting, was where we started talking about this HCPF writing into the rules the ability to limit the number of case management agencies within any service area. The question is, to what extent will you exercise that authority once you give it to yourselves in the rules, so to speak?
Yeah, thank you for that, Elsa. And I am drawing a blank right now on the House bill in 2017. I think it was 1372 that require the department to implement that third-party broker and allow for case management agencies to provide both direct services, just not to the same, and case management, just not to the same person. When we passed 1187 or 21-1187, it actually repealed that language and replaced it. And so that is no longer, the department no longer has the authority for that. So I appreciate that, that comment, and it was a great question.
Thank you. This is John again. So we'll move forward at this point. I think the current slide is up on the screen.
All right, thank you. So quality currently, we have a couple areas where we provide oversight of case management currently using our quality improvement strategies, or what we refer to as QIS. And, this is an annual review across all 10 waivers that we conduct. There's a sample size that's based on the total waiver population, but it's not specific to each case management agency. And so that can create some current challenges. We also use the national core indicators, which are satisfaction surveys that go directly to members and their families. And then we do targeted programmatic reviews for case management agencies. The content may vary based on specific concerns that are identified. And then we do financial reviews annually of case management activities and associated payments. So for case management redesign and future state, if we look at the next slide, the oversight of case management activities, we want to move to a statistically valid sample size for each case management agency, which is a large difference from how we're currently doing it. We are shifting to more of a continuous quality improvement model. So on an annual cycle, we'll review case management agencies' performance using that statistically valid sample size, and then use the performance measures from our waiver and additional metrics that are determined, including the NCI satisfaction, to assess each agency's quality performance. And then we will create and publish an annual scorecard of case management agencies' performance on a predefined measure. so that every year over year we'll be able to see celebrate the good work that's happening and the areas for opportunities in a more transparent way, which I think is really important. And then we'll continue to review the case management activities and associated payments. In addition, we currently have an ARPA project that's focusing on the development of a child and family satisfaction survey so that it can be utilized for members using our children's waivers, as I think that is also a very important piece that we're currently not doing that will help inform and drive the work that we're doing in the future. You know, this changes to case management oversight will allow the department to, I think, have better line of sight and hands-on to oversee case management agencies using that statistically valid sample size, and then be able to do targeted training and technical assistance in a more responsive manner with our case management agencies. And so then if we go to the next slide around training, you know, we've heard throughout our stakeholder engagement, just the importance and value in having consistent training for case managers. And so, you know, our existing training that's available to case management agencies isn't always interactive and is not being delivered in the most effective format to support adult learning styles. The current training materials lack the evaluation functionality, making it challenging to understand retention of materials and information. And we also have the disparity in training approaches and application of these materials because the department has a core set and then each case management agency has their own training. And so going forward, we will have all of the training be updated to support that interactive learning model that really supports more the ability to do the tests and the checks to make sure that there's the retention of the information. We can see and track who's taking the training. It can be assigned if it's identified there's areas of concerns or gaps. And all of that will be managed through a learning management system. We will be empowering case managers to have more consistent training materials and giving them the tools and the resources that they need through the efficient and more effective training models. This will be available to all case managers, and again, really focusing on more competency-based training assessments to really be able to understand and evaluate that comprehension of the materials. And so then to round out this section on the next slide, case management agency rates is something that the department is really wanting to make sure that we support the ability for the case management agencies to achieve the goals of case management redesign. And so one of the things that we have heard really loud and clear is that the current caseload sizes that case management agencies have vary across the state from agency to agency, but they're oftentimes very large and untenable for a case manager to be able to really support individuals. And so the department is looking at setting a standard caseload size for our case management agencies so that we can have best practices, but also understand that the rates for case management activities need to support this. And so we have a budget request this year that is $8 million to infuse a little bit over or just under 8% into the total case management appropriation. And so our ongoing case management proposed rate will be $117.35, which is for ongoing case management. And then there will be additional payments for contract requirements, as well as payments for monitoring visits. When we look at our caseload size, we are looking at a ratio standard of 1 to 65, but also have provisions in there allowing case management agencies to propose to the department alternatives to that if it makes sense from their business model. We expect that case management agencies will still have a varying of caseload depending on how they structure or set it up to make sure that it meets the individual's needs. So if there's a specialized population group that needs smaller caseloads, that may make sense. If there's another population where maybe they need or it makes sense to have higher caseloads, that makes sense too. So we want to allow for flexibility, but also really put pressure on that standard so that we can start to really address some of the challenges with high caseloads. I will just also offer that the department hired contractor Myers and Stoffers to conduct a study to really look at rate methodology and provide recommendations to the department on how we're currently paying and future rate structures. And that rate study will, with those recommendations, will be posted to our Case Management Redesign webpage within the next week. So that will be online soon. All right, with that, John, I'm going to stop.
Thanks, Amanda. John Berry again. So we're taking names and chat comments for the queue. If you want to raise your hand in the webinar, thanks, Jen. We'll get to you. Anyone else? You can unmute your computer or phone and give me your name verbally at this point. Thank you, Pat. Looking in the chat to see if there's any names in there. Michelle, thank you. Hey, we have 3. Let's stop there. Come back for it if time allows. Jen, let's start with you.
Okay, so it seems like the big issue is having a choice of case management agencies in particular catchment areas. So my question is, do you fight that and have more than one? Do we need to fight this House bill?
So Jen, I appreciate that question. And I think, you know, from my perspective, I feel strongly that no. I think that, you know, choice in your case manager and who your case manager is really important. Who they work for and the agency in which they work for feels like that's a different component. And so I would really like to move forward and see that, you know, majority of individuals receive services and their case management agencies meet their needs. I think that is why it's really important for the department to have an exceptions process. Or as Abby referred earlier, you know, there is a subset of a population that maybe what we're proposing isn't going to work. You know, I think that's a different conversation that we can look at. But you know, for the department, we feel strongly about the model moving forward and really that it's going to address a lot of the challenges that we currently have in our system, but certainly have the grievance and complaint process that we need to make sure allows for that provision. If there is a case management agency not meeting an individual's needs, that they could then choose one in their surrounding areas.
Okay, so just for make sure I have this right, the department thinks that the new system will alleviate the need for multiple case management agencies because you want us to change case managers within one agency. Is that correct?
Yes, so I mean, that's one of the huge things we're trying to address is that depending on which waiver you want, you have to maybe go to a different, you have to go to a single entry point or a CCB. As Colin addressed earlier, people may meet the criteria for multiple waivers. And so in our future state, like if you age out of the system or you move between waiver programs, you don't have to make a change in who your case management agency is.
Okay, thank you.
Yep.
Thank you, Jen. Pat Chamberlain, you're up next.
Thank you, John. This is a question about case managers and the high turnover rate of case managers. And we have found it difficult as a family. We've had many of them. We have a great one right now that we're very happy with. And we want to know who at HCPF is looking at case manager pay, how to retain the most qualified people and incentivize them to stay. Because even with these new trainings and the new rollout of this system, a lot of people are leaving. And I think that it's essential that the HCBS address this. What's being done?
Yeah, thank you for that, Pat. I mean, it is my goal to try and keep as many case managers in our current system. I mean, they certainly are, you know, heroes oftentimes every day in people's lives to be able to navigate this, and you know, trying to keep all of our case managers is something that's front of our mind. And so we have a number of work that we're doing under the ARPA funding, in addition to case management redesign, around recruitment and retention. We're going to try to, you know, short term, we sent out a survey about satisfaction to the case managers themselves to understand, you know, like, what do they love about their job, what's working, what's not working. We have a study to look at compensation, so salary analysis for case managers, so that we can really understand what that looks like and what that means. And then we're doing retention payments for the case managers starting in probably, our hope is to roll it out in December. So it's about December, January timeline, and do a couple retention payments throughout this transition so that we can keep them within their existing organizations. And then with case management agency executive leadership teams, we're having statewide conversations about recruitment and retention strategies that are working, and doing some sharing there, because I agree with you. We really need to retain all of our case managers, and in case management redesign, we also need to recruit additional case managers.
Thank you, Amanda. I just want to add to that. I think that you need to look to vertical pay scales. Retention is a horizontal pay scale retainer kind of instrument. You know, people that are in their jobs get paid for staying in their jobs. What you lose people for is there's no way to move up. But now that we have case managers responsible for more than one waiver, for instance, maybe we reward people when they're more knowledgeable for more than one waiver, or each time they take training in a new waiver, or those kinds of things. And what can you do to help those people improve their salaries through their lifetime so we keep really qualified people? Thank you.
Yeah, I love that. Career lattice thing is important.
Thanks, Pat. So now we will go to Michelle in the queue.
Thank you. So my question is kind of goes along the same line with caseloads and part of the transition. I'm speaking as both a parent and as a provider. It's my understanding that CHCBS has the highest utilization in El Paso County, and whichever case management agency wins the contract for the El Paso County area, to include probably Teller and Park, my concern is 3 of the 4 private agencies are based out of El Paso County and probably contribute to that high level of CHCBS utilization in El Paso County. So when you look at this transition, you're talking about the awarded case management agency taking on an influx of around 1,200 CHCBS members. How is that transition going to work? If you're talking about a 1:65 ratio for case managers, that awarded case management agency would have to hire a minimum of 20 case managers just to be able to handle the influx of new cases, or I should say ongoing cases that will be transitioned from the current private case management agencies. What is the state doing to work with this transition process?
Yeah, thank you for that, Michelle. I appreciate that question. And so some of the work we are doing is leveraging our ARPA funds to provide technical assistance and coaching for case management agencies to plan and prepare for the transitions. We did have to put a pause on that technical assistance until the RFP closes. And so we will have in in March, we will resume that one-on-one coaching support for each agency to develop a transition plan for all of their members, and what that looks like. So we'll be able to really have hands-on support, and then make sure we have a plan for each organization. And that may inform some different strategies in terms of which agencies transition in the 3 different phases. But it is our intent to make sure that we minimize impact to members. We have done some transitions even in the middle of the pandemic, and have put in place, I think, a very robust transition process to really support incoming and outgoing agencies. So I appreciate that, Michelle, and I think we have put a lot of thought around that and made sure that we have some support for every organization, both incoming and outgoing. So Colin, I saw you popped on, and I think it's because I lost track of time. So
No, I was going to jump in. I've been following the chat. Travis, I think, asked an excellent question about training around direct support professionals, direct care workers. I think I just wanted to acknowledge, and Jose is certainly in there as well, sort of reiterating what a lot of people are saying, which is the ratios are too high. There's a really stressed workforce, both emotionally, but in terms of overall capacity. And unfortunately, that's the reality that a lot of the long-term care system, I would venture most of the long-term care system, is facing right now. Over the last 4 years, I've had the opportunity to really do a deep dive and learn a lot about the direct care workforce and people that are part of the system and that ecosystem. And it's hard. It's frankly hard everywhere. And that's not an excuse by any means. But there are a lot of different things that we're trying to do to help that situation, knowing that there's not one silver bullet out there. There's not one single answer that's going to solve all of this. We do know a big piece of this is ultimately funding, which, to Amanda's earlier point, we are increasing. But there also has to be new entry points. We have to go after new people who maybe don't even know this work exists. We have to engage community college systems. We have to engage higher ed and Department of Education. All of those things are starting to happen now. Those are things that are active within our American Rescue Plan Act work. And we understand that there needs to be more case managers, needs to be more direct care workers and direct support professionals across the system. It is in crisis, and we acknowledge that. And we're doing our best within the resources that we have to change that. There's a lot of different opportunities for people to get involved in that conversation. I pasted that earlier, and I'll repost it again. But just acknowledging it's tough out there, and we have work to do. The system has work to do overall in recruitment and retention, frankly, making sure people respect these careers, respect the individuals who are providing these services, because they are integral to what we do in Colorado and making us such a successful state. So wanted to acknowledge that, let folks know we are working on it. We are understanding of the situation, and we're trying to get better. So appreciate the comments, and we will do our best to move forward with what we have.
And Colin, if I could just add to, his team has done a phenomenal job and really working on workforce and has been gracious. And so trying to make sure we have a track for our case managers to equally address it. So we have short-term and long-term strategies. Like, it's not something we can stop the conversation anytime soon around, because even before the pandemic, I think we had challenges. I think the pandemic certainly highlighted those. But I will also share that, one of the pieces to case management redesign also is, a new IT system for case managers, which we are calling our caring case management system, because currently our case managers have to deal with 3 different IT systems. We have the bus, we have the bridge, and we have what's called the DD web for those individuals who are using the wait list and supporting individuals on our DD waivers. And so our new care and case management system will hopefully alleviate some of that duplication in data entry and just administrative work that is required by case managers, that takes away their time for actually being able to spend with members. And so I think that in addition to all of the pieces that we've been talking about today, we also have been working really hard on getting that new system in place, which then will allow for, the new assessment and support plan and other programs. But we have to do a better job of taking away some of that administrative burden for the case managers.
Okay, thanks everybody. This is John again. Elsa, you were up next in the queue. See, you lowered your hand. Is that correct? I will move us on to Michelle and then believe we move forward. Michelle?
Thank you. So Amanda, this is kind of to go back to when I had asked you about the handling of influx going towards one particular agency. And you had mentioned the technical assistance that was being provided but had been paused until after the RFP closes. I guess my question is going to be, why was the technical assistance paused until after the RFP? And the reason I ask that is because agencies, whether they are current or new agencies that were going to be moving forward with the RFP process, that was the technical assistance that we were given in order to put our plans together. I will speak to myself as a private case management agency. We had intention of subcontracting or attempting to subcontract. And once our technical assistance was paused and shut down, we are now having to make the decision to not move forward as an agency or with the RFP process. And so it doesn't make sense that you would pause the technical assistance until after the RFP process closes.
Yeah, I appreciate that question, Michelle. And for the department, you know, protecting the integrity of the RFP is our priority in terms of making sure that we don't end up in a situation where one organization or one entity or one group has information that isn't available to everyone. And so there was very hard conversations that went into that. And ultimately it was determined to protect the RFP that we needed to pause that. So, I mean, I can certainly have a conversation with you directly about your organization and the impacts that's had. But I think for the department, we feel really strongly that that was the important path forward. So I hear you and I appreciate that, but it was very necessary for us to do that. All right, John, I think we are ready to move to the next section.
Great, thank you.
All right, so circling back, you know, Colin did a great job in the beginning talking about, you know, what's not changing, and really wanted to make sure that after all of this conversation and discussion, you know, that we make sure to speak, how does this impact members? And, you know, we're certainly working hard on this in with our goal of trying to improve the current programs and improve access to services and simplify for members receiving services. You know, you'll still receive the same day-to-day services you're approved for. The programs and the services are not changing. Case management activities for approval will continue. You know, for our CHCBS children members on waivers who want to access adult programs, you know, in the future, you won't have to change agencies when you go from the children to adult waivers. You know, the one thing that is changing is that, you know, your case management agency may change. And I want to make sure that you hear me say it might change. We don't know if your agency is going to change until May, as we talked earlier, but there will be a very robust and detailed transition and communication once all of the changes around case management agencies are impacted. So on the next slide, then, you know, department communication with members, you know, want to set the expectation that case management agencies are also responsible for notifying members on case management agencies and case management redesign. We work closely with them to provide, you know, fact sheets and information so that community conversations and discussions can happen. And we also know that there's a level of ambiguity for the case management agencies right now too. And so, you know, there is some grace and confidence at the local level there. Case management agencies are expected to use department materials and talking points to provide information, because again, like, there is ambiguity and there is changes happening, but we also want to make sure that we can quickly address and dispel any myths around case management redesign. We want to maintain timely and accurate flow of communication from the department, and we want to ensure that members know where to go for the information around transitions and case management redesign. And so we've worked really hard to try and build out our website and keep everything on the case management redesign page with the timelines and updates. We are, host the webinars, which not only this one that we do about every 6 months, but we also, if there's key updates for our case management redesign, try to infuse those in our monthly Office of Community Living webinars. We again have talking points and information that we provided for the case managers, because oftentimes the questions you have are at a local level, so we want to make sure that they're prepared. We've done some listening sessions and surveys, and we'll continue to do all of those throughout this process and beyond. So I want to be clear about, 2024 isn't going to be the department goes silent and we stop talking about case management and the redesign work. So we will continue on those. We'll host a question and answer session about case management redesign. In about 6 months from now. We'll use the contractor for member trainings and member materials across the state by region. We have been working with Colorado Cross Disability Coalition on developing some short videos and informational materials so that we can get those out statewide, but that will be later in probably next spring. And we'll continue to host the sessions, and then we'll send actual snail mail out to members impacted by case management agency changes once those awards are announced. So with that, John, I'm going to turn it back over to you.
Thank you. We are now on the next slide, the open discussion. So let me gather names for the queue. You can raise your hand in the webinar. You can unmute your computer or phone audio and give me your name verbally right now, or type your name in the chat. Anyone on the phone or computer audio?
John, I saw one just pop in my corner of my eye that I wanted to speak to, and it's a question about remote case management or virtual case management. And so we've heard from individuals and families that, for some people this works great, for others it doesn't. And so we have issued guidance to case management agencies that they really need to work with each individual to determine what mode of case management works best for them. In person or virtual, that is really to be the member's choice. And so I just wanted to speak to that because I think it's really important for members to be able to make that decision.
Thanks, Amanda. So let's go to Jen in the queue. Jen?
Thank you, John. I'm sorry to ask again, but I just want to be clear. You are expecting members to trust your process design and not worry that we're not going to have multiple case management agencies per catchment area, correct?
Yes. So, currently right now, where you live, depending on your waiver, there's already an assigned case management agency. Depending on which waiver you have, you receive your case management from that organization. And so future state, it will be similar, right? Depending on where you live, there will be a case management agency that serves that area. And in May, we'll know who that will be, and we'll send out communication to members so that they know who their agency is if it's changing.
All right, thank you.
Yes.
Thank you. Now we'll go to Kelly. Kelly, thank you.
Thank you. I heard somebody speak, and I'm sorry, I can't remember who it was. Is it true that there are only 4 CMAs in the whole state that service the CHCBS waivers currently?
No, there's only 4 private CHCBS case management agencies. Our single entry points also provide CHCBS case management, and some of our community center boards do as well.
Okay, so but out of those 4 private agencies, 3 of them are in El Paso County is what was stated. Is that correct?
I believe that is correct. And they serve, I think majority of their, they serve statewide. So they don't have individuals just in El Paso County. I don't know off the top of my head the breakout of members.
So is it fair to say that given that information specifically to the CHCBS waiver, and I realize that's only one of the 10, but that there's going to be a very high percentage of individuals on the CHCBS waiver that will be moving CMAs?
That is correct. As Michelle had mentioned, though, that each of those organizations are at various stages in having conversations with other entities about what potentially that might look like in their area. And, you know, because of the RFP process, the department's not privy to all of those conversations.
Right, but if there's 3 alone in El Paso County, and there's other CCBs and everything in El Paso County, and you're going to be taking all of those agencies down to 1, there's going to be a high percentage of people affected specifically in that area, correct?
Yes.
Okay. I'm just putting it out there so that I know what to take back to my area. So not only people being serviced in El Paso County, but specifically the CHCBS waiver are going to be disproportionately affected by these changes. Fair to say?
Potentially. I mean, I think, you know, the reason why I can't give a definitive answer is, you know, I think there's conversations happening around maybe there's going to be a subcontractual agreement. Maybe some of those case management agencies actually go to work for the entity that is awarded the contract. And so I don't think we can say at this time what that impact is going to look like definitively.
So there's, okay, so that's something new that I just took away from what you said. There's going to be subcontracts available through the entity that's awarded the CMA contract for that catchment area. They'll have the ability to subcontract out potentially existing other companies.
So currently, all of our case management agencies in their contracts have the ability to subcontract up to a certain percentage of the total contract amount that they provide. And so we do not anticipate that being a change that we will make going forward. So the answer is yes, that is a potential possibility that we have been talking with the case management agencies that provide CHCBS waivers. And in public meetings, we've talked about, you know, options going forward. So yes, that is something but that is a business decision that has to be made for all entities involved.
Okay, and I just want to put a plea out there again that you please, HCPF as an organization, please remember that the families affected and the individuals affected by all of these waivers should be your #1 stakeholders. And I put this in the chat earlier, but I have felt for years that HCPF does not value the families and the individuals as a stakeholder in all of these decisions that you make. So please, please remember, when you throw around the term stakeholders, there are still many of us that don't feel valued under that term based on the way that you treat us and communicate with us. So please, please just remember that that's very valuable to us to be considered a true stakeholder and be kept apprised of all of this information.
Yeah, I appreciate that, Kelly. And it is certainly, you know, I think something that our leadership team at HCPF really values hearing from families directly and doing listening sessions and feedback. I mean, I think, it's hard because at the end of the day, like there isn't a one decision that unanimously meets every single person's needs. And so it's trying to incorporate the feedback from all of the different groups and coming up with a solution that makes the most sense for the most, and then allowing for that flexibility and exceptions process always, because there's always going to be situations or circumstances that don't fit into, clearly defined rules and regulations, right? And so that is really important to us, and I appreciate your feedback.
Thank you for your time.
Yes, thanks for joining.
Thanks, everybody. This is John Barry. So I think we have time to gather names here for the final round of comments, questions. You can raise your hand in the webinar. You can unmute your audio and give me your name verbally. Type your name in the chat. If I can figure out budgeting the time before we need to wrap for today. Are seeing nothing, no new names in the chat. And no hands raised in the webinar. One more time. Anyone, folks? Okay. Randy, please go ahead. Thank you.
I had actually typed it in the chat. Can you hear me? I'm using a headset, so.
We can hear you.
So I'll just read my question. In listening to all of this, and I know, so I am an autistic self-advocate. I'm also a parent of a child on a waiver that's transitioning soon. And so there is a lot of fear. I'm very active in the community in Northern Colorado, and there is a lot of fear in families with this transition, including my own. So my question is, what is HCPF doing to prevent fallout for families with this transition? Example, like annual recertifications. I don't know the technical word that the CCBs use, but the service allocations that go out to the PASAs, right, for services. Is there anything being done as well to disseminate to families or individuals on how they can get quick resolution, not your grievance process, because there's nothing quick about that, but quick resolution if an individual is negatively impacted from this transition? I fear that as these transitions happen, individuals and families are going to fall through the cracks. And that concerns me as a community member, as a family member, and as a person with a disability myself. So that's what I want to hear. What is HCPF doing, and how will they respond quickly to these concerns?
Yeah, I appreciate that. And so once the notice of intent to award is notified, we quickly have meetings with each of the entities, the incoming and outgoing, and then we establish weekly meetings with them through all the way up until the transition, and then 6 months post, so that we are tracking and monitoring. We are able to see, whose CSRs are coming due, or renewals, or, as you said, determinations. So we're able to track that really closely. So in the transition, we can see if something, was missed or there's a delay. And so I think we have pretty tight internal processes in place to really support case management agencies, and that's part of the pre-planning work that happens is looking 3 months ahead of who needs what, so that so things can get done in advance and then afterwards. So I think that we've done quite a few transitions over the years, because we do have some case management agencies on the single entry point side that have transitioned to be able to really refine that process, so there isn't that gap for individuals in their services. But again, your approvals and your support plans, those won't change, nor will the timelines. And so there will be, I hope, it's our intent to make sure that we're able to monitor and track that closely.
Thanks. This is John. Barry Froney, you're up next.
Sorry, I had to unmute. my point is, somewhere in the slide presentation is mentioned a consumer advisory council. I think it was under quality or something. So my suggestion is that the names of the people on the Consumer Advisory Council be widely published throughout the whole HCPF waiver user community, so that if someone has an urgent need, instead of waiting for the bureaucracy at HCPF to get around to their concern, the names and email addresses of everyone on the Consumer Advisory Council be available, and that family can just, yell help through an email to other advocates, and those advocates can make sure that that urgent issue is addressed. It gives more power to people, and the people who are most concerned and most able to scream and yell about the urgency of an individual's need are other families and advocates. So I think that would be a great process, and a HCPF should not wait too long after the May announcement to publish the names and email addresses of everybody on that advisory council, so everybody, every Medicaid member in the state can know who to go to if they run into an urgent problem, a lot faster through another advocate or family than through a bureaucracy. Thank you.
Great, thank you for that, Jerry, and I appreciate that. That aligns with what we're hoping for these councils to be able to do. I will just share that that is future state, and so it will be something that will be not available right at May, because there is going to be a transition period for the new agencies to take on the new case management contracts and requirements. But yes, that is the intent.
I don't know why it can't be done in May. If HCPF wants it to be done in May, it can be done in May. Thank you.
Thank you, Jerry. This is John. So we have about 1 minute left before the wrap up. Jen, please go ahead.
Yes, thank you. So I'm just suggesting that if you want members to trust you in this new agency, one per catchment area, you really should allow advocates on your panel board.
Thank you for that, Jen. I appreciate that. I think, we also want to make sure, how do we get input from advocates and members across the state, and so how do we do that in a way that also protects the integrity of the RFP? And so I hear you, I appreciate that, and I think we spent a lot of time really digging in and figuring out like how do we do that in a way that also, knowing that 20 hours a week for 10 weeks is a huge lift. And so, and making sure that we have representation statewide. And so the survey will align with contract requirements. And so there will be input specific to each of those subsections. And so we'll make sure that we get that out to everyone to be able to give their feedback in a very safe way that can help inform that process.
I just want to point out that I am an advocate who does not work, so 20 hours is no big deal for me.
Okay, thank you.
Thanks, everybody. That brings us to the end of the open discussion period, and I will turn it over to the rest of the team.
All right, well, I just really appreciate all of your feedback and input and discussions today. And, I think we certainly have a few action items that we will take back and, want to have some additional listening sessions and really appreciate your time as we navigate through all of the different case management redesign changes that are underway. And I hope you all have a wonderful afternoon, and I'm sure I'll be seeing you soon.
Thank you.
Thank you. Have a good day.